here, then we put it here. When we check this, then we were one level above. So we again trying to ascertain that here we get our targeted level. That there is a facetal arthropathy over here, so our targeted level is here because there is a listhesis. So targeted level is here. Here we need a greater drilling of upper lamina to reach at a discal level, or we can do a sublaminar drilling to decompress the same side of area. 100%. You can put your incision 1.5 centimeter above the point of the needle insertion. So we can do some Kirison punching over there. So level is confirmed, and now we are giving our step incision. Please show the camera over there. Now, now we will shoot a we will save a X-ray image and later we relay from here. Yes, few more shoots only. Not needed to shift it here. You can shift it. Make a rule. Shift it every time whenever you are changing the position. Lateral should be shifted here. AP should be shifted here. Hope you can see the picture of the operating field. Yes. Some more medial if possible. Yes. So you can show here. ये करते रहना. So this is our entry point. We have placed our stab over here at spinolaminar junction, just above the lamina, 0.5 centimeter above the laminar window. Show there. So our dilator is placed over the lamina. Yes, we are just checking in the lateral. Take a epi shoot over here. Take a long course.
So, this
yes,
is.
Sir. Welcome, Anurag, sir.
Thank you, Anshul. You are demonstrating very well. And thank you, Shubhendu. Doing very well. And you all are lucky. You must consider that how lucky you are that in the initial years and period of your practice of pain medicine or the training of pain medicine, you are witnessing such high-end MIPSIs. Endoscopy, spine endoscopy as we call it, or we call it MISAP, minimally invasive spine endoscopic pain procedures.
Media.
So this is the terminology which has been given by the Indian Society for Study of Pain for the benefit of all of you. Why it is important? Because some of our colleagues like to call it surgery, but it's not surgery. We consider it as the endoscopy, like the like the angioplasty, like the angiography, like the endoscopy done by the gastroenterologist friend. So this terminology argument is equally important for your survival and flourish in the field of pain medicine. You must understand, and this is something which I know that not all of you are going to practice the endoscopy, but this is the definitive treatment. The world is moving towards the definitive treatment. If you get a patient, tell me how many of you are actually practicing the pain medicine. I believe most of you. What are you going to offer to your patient who is coming with a claudication symptom, and on the MRI you find 2 levels of stenosis? The patient age is of 76 years old. Bones are osteoporotic, and on MRI you are finding lumbar canal stenosis, severe lumbar canal stenosis because of the ligamentum flavum thickening along with the facet joint hypertrophy. What MIPSI are you going to offer to this patient? Is it anything going to work? Yes, you can say that, sir, I will try the caudal MIPSI, I will try the bilateral transfemoral MIPSI. Is it going to help? Yes, initially it will going to help for 2 days, for 5 days. Are we living in America where they like to put the series of 3 epidurals for any radicular pain? No, we are not. Our patient is paying from the pocket most of the time. They want a permanent solution. So, what else can you give if you are not decompressing this patient? And if you are decompressing, there are only 2 ways. You refer the patient to your surgeon friend who is doing the spine, and he do the laminectomy, wide lateral laminectomy, removal flavum, fixation and fusion of the spine of that segment. Is it a good choice? Yes, in some cases it is. Is it the only choice? No, certainly not. Endoscopy, MISAP procedures are there, which can relieve the patient from their complaint by the posterior decompression of the ligamentum flavum with a less than 1 centimeter, to be precise, 1 buttonhole size incision, under local anesthesia, under epidural, under caudal epidural, or whatsoever, spinal or GA, as per your choice, as per the patient condition. So it is very important for all the young pain physician to understand that spine endoscopy is also the part, MISAP procedures are the part of your curriculum. They are the part of DM courses, they are part of PDCC courses, FNP courses, even FIAPM is a desirable thing. So you all should aspire to well verse in the percutaneous spine endoscopic intervention. Now you can see that Shubhendu has put the dilator in a beautiful manner on the spinolaminar junction. So try to visualize in your mind where is the spine, where is the lamina. So what is spinolaminar junction? So this is the junction of the spinous process of the upper vertebra with the upper lamina. So usually we like to end up there, and then we try to dissect by drilling the bit of bone and then by removing the flavum. You will see in the little bit of time. So they are very powerful interventions. Society needs it because what happens? Bones are osteoporotic. Patients are having multiple comorbidities. Your smaller regular MIPSIs are not going to last. So what is the option? Most of the patient, if they go for the fusion fixation in this age with the weakened bones, they land up many times unfortunately with the complications as well. पता चला जो failed back surgery syndrome जिसके लिए finally फिर stimulator लगा रहे होते हैं, dialysis कर रहे होते हैं, why to go there if we can save the patient from that place? Yes, there are indications when there is a burst fracture, there is a completely unstable stasis. Certainly it is not going to help. We have to send the patient for the fixation fusion. So I hope you all watch it very properly, very keenly. Keep the question in your mind. Ask. Sojanya herself is practicing endoscopy a lot at Vizag, and she is of your age only. She is your friend. तो अभी वो बीच में बताती रहेगी. पूछते रहो. Keep yourself engaged and feel yourself lucky to have witnessed this thing. Only to see this type of cases, people spend 50,000 to 1 lakh rupees. Okay? Come on.
So here we have taken the final AP shoot, and our sheath of the dilator sheath is snugly fitted in the interlaminar window of L4-5, in which L5 is sacralized. So we are just finally checking in the lateral view. Shift it on the right side. Yes, this is the lateral view, and we are directing towards the L4-5, L5 sacralized, last visible disc space. So we are starting over here. Just shoot and remove the C-arm. Move your camera towards the operating field. So now there will be no need to see the C-arm views. So we are removing the C-arm and we are moving our camera towards the endoscopic view, endoscopic hand view of the surgeon. Surgeon hand movement is very operator hand movement is very necessary to observe in the endoscopy. So how we held the scope and how we move our instrument tip should be visible at each and every step of the endoscopy. So many times we have to move the things on the angles, like we see our camera, like we have to move our camera like this to see the tip of our instrument over here. Cutting edge should be opened clearly and should be visible at the every step. So we are starting. Hope the endoscopic view is getting over there in PIP mode. Please confirm. Are you able to see the endoscopic picture?
Yes, sir, we are.
Okay. So scope we are using is 5.8 internal diameter, 5.7 internal diameter RJ scope, and 15-degree angle, 125 centimeter length, 125, 125. Yes. So it is the most widely practiced scope in PSLD nowadays, and we should use a compatible plasma for this. Many plasmas are not going through aperture less than 6.1. So whenever you are buying combination of plasma and scope, you should take choose the compatible one.
That's the plasma RF that they use.
So here we are using Endovision plasma RF. So you can see how nicely it is performing and clearing the soft tissues from the spinal laminar junction very fast. So hand movement, we have to keep our sleeve held with one finger. Sleeve should not be sinking in the interlaminar space during interlaminar procedures and post PSLD procedures, endoscopic procedures, when they are done from the posterior side. So it should be engaged in the hand, like Dr. Shubhendu is engaging the sheath with one hand and keeping a scope held on the thumb with support of the light cable. So this handling of scope is very essential, and his little finger is just touching the patient body to making another safety. So hope you are clearing the soft tissue from the ipsilateral laminar IAP junction. So we will clear the all soft tissue from the spinous process, lower lamina of the L4 vertebra, IAP, and then lower lamina. We can see the part of SAP only after drilling the inferior articular process. So our plan is going for above the lamina, or we are clearing from ipsilateral side, then we'll go over the top, under the top. So there are two approaches to do the PSLD. Over the top, in over the top we clear the whole bony lamina first, and then we will remove the ligamentum flavum in toto after drilling of the bone from ipsilateral side and contralateral side. And there is another method in which we drill ipsilateral window wider, and then we will remove the ipsilateral ligamentum flavum, and then gradually after drilling the base of spinous process we will go towards the opposite side and remove the ligamentum flavum visible above from under the toe. So now he is using the radio frequency probe, a smaller one, and it is easy for palpation and delineation of the tissues and coagulate the marginal bleeders with high accuracy. Why we are using radio frequency probe over here rather than bipolar and other energy source? Because of it is having very low penetration in the tissues. It is just coagulating the vessels, not damaging the other tissues. It is having the penetration of 2 nanometer only. So we can think that there is a very less and less penetration and very less and less collateral damage. So this is bone which is touched with the forceps and delineated. So bone basically it is upper lamina, and we can see the angle that we are going translaminar. We will remove this bone with the kerison. If we are going with angle, then our kerison will work over here very nicely, and if we are going straight, then we have to use burr more. Hemostasis is very important step during the procedure. We have to coagulate each and every bleeder to make our field clear. Otherwise, our field will be spoiled and it will take time to do our procedure in a stepwise manner. So, clear every probable bleeder, not a bleeding site only. A probable bleeder, probable vessel which can bleed later on should be coagulated first, and vision it should be made clear. So here we are using annulus cutter to clear the soft tissues from the spinolaminar junction. We coagulate all the soft tissue before cutting. So this is a very important step, that we should cut the soft tissue only after coagulation with the radio frequency probe or plasma probe. If we are above the bone, above the phlegm, plasma is a good choice, reasonable choice, and it depends on the person who is doing the procedure in which he is friendly, plasma or radio frequency. If it is a good radio frequency generator, then it is only suffice for the procedure. We can do anything with a good radio frequency generator. So this is a small length interlaminar radio frequency probe. You can see that there is not a larger one. Many people are still using a transforaminal one, longer probes, which are easily available, but they are more cumbersome to use. You need
Yeah. So that's all the bony structure that he's trying to feel. Most of it is a laminum. Maybe he's just trying to find out if he can get an interlaminar window somewhere. The feel of it gives as he's doing that he's trying to feel if he can get a window somewhere between the bone and between the two bones, between the two lamina. So once he gets, once Dr. Shubhendu gets the interlaminar space, he'll try to go in and then start either using a Carrison or a burr, whatever he would, whatever is his choice. With Carrison, there are different sizes of Carrisons also, where we just nibble the bone, or we can chip out the bone. So basically creating a window to assess the ligamentum flavum. So among burrs also, the different kinds of burr. I think he's going to use a diamond burr. Let's see what he's going to do next. Yeah, so basically this shows that it's time for them to change the fluid.
पानी चलने दो थोड़ा, क्लियर दिखता रहेगा. निकाल लो, प्रोब निकाल लो अभी थोड़ी देर.
It's also
कैमरा
important
निकाल लो
how,
उसकी lateral
how
position
much
के बाद में
pressure
डालो.
of the fluid goes,
बस.
because more if
ठीक
the
है, अब
pressure
करो.
increases, the patient, if you're doing the procedure under local, the patient will tell you that he's got
नहीं,
neck
नहीं.
stiffness.
हाँ,
So
वही
that's
डालना
when
है.
you know that
Lateral हो जाने
the
दो.
pressure is increasing, so you need to decrease the pressure of the inflow of the fluid.
एक बार
Trying to take a shot.
निकाल लो. So we again reconfirm that we are in the interlaminar window of the same level, and now we are going inside with drilling. Okay. So we are first clearing the margins, then we will drill the area, then we will remove the ligamentum flavum attachment, then we will clear the superior articular process of the both side. Only tip.
clearing all the tissue over the laminum. Anyone interested in practicing endoscopy? Yes.
So window is very